Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon, joined today by my co-host, Samantha Murrell.
Hey everyone, Samantha. Good to be here. I have lung cancer, stage 4 with a HER2 mutation. I'm a patient advocate and I'm happy to be here. Thanks, Kyle.
No, thanks for joining again. And I'm a physician scientist at the University of Colorado. And today we're going to be talking about how cancers evade treatment through transforming from essentially one type of cancer to another type of cancer. This is a really important topic because it's happening more and more frequently. We call it histologic transformation. And it's something that should be, I think, on the minds of individuals who have cancer to raise with their oncologists if they're on a treatment for a long period of time. Is this something that could potentially happen in my cancer? And how do we evaluate for it if that concern ever arises? And Samantha, you reached out to me to say, hey, why don't we do an episode on this? Because you're hearing a lot about it in the advocacy communities, and it's, I think, a genuine fear of people, and we'll go into why. Mm-hmm. But, tell me what you've heard.
Yeah, I mean, in the lung cancer community specifically, I'm seeing more and more, and this is very specific, and I think initially we can talk more broadly, but what I'm seeing is people that have the EGFR mutation in particular. And I don't know if that's just because more people have the EGFR mutation, right, compared to other mutations, or it's this specific mutation, but it seems to be that this mutation is transforming, I believe that's the appropriate word, into small cell. And it's quite alarming for people to learn that this can happen. And it's been happening more and more to people that I know. And unfortunately, one of my very good friends passed away very recently, Caroline, from this transformation within 6 months of being transformed to small cell. And so I'd like to dedicate this podcast to her. She asked that we do this podcast because it was very near and dear to her heart. Just making people aware that when they're diagnosed with X, things can happen and things can change. And it completely puts a whirlwind on your experience because you're expecting XYZ treatments throughout the course of your cancer. And when these transformations happen, you're suddenly looking and facing at all these other treatments that you didn't even think were a thing for you. So as I said, I'm seeing it more and more in lung cancer specifically. But I would love for us to touch on initially, like, how often does this happen in other cancers, or is this more of a specific lung cancer trend that we're seeing?
Sure. And, our thoughts and prayers are with Caroline's family. And it's devastating because particularly in lung cancer, we have a series of oncogene drivers. There are a series of mutations that tend to cause many types of lung cancers, like the one that you have, Samantha. Mm-hmm. And generally speaking, we have good ways to target those. And this kind of paradigm is true in other cancers too. Sometimes you'll have specific ways, unique ways you can target that cancer. And that cancer is really susceptible to that. You're on a pill right now that targets your HER2 mutation really well. You're tolerating it well. The cancer is, behaving. It's responding to the pill. And then when you get these transformation events, they can no longer be sensitive to the therapies that were really, really effective. And then you're down a whole different kind of avenue of treatment, so to speak. So this idea where cancers can evolve, they can change what they are kind of fundamentally, is something that's seen across the different types of cancers. It's not just a lung cancer phenomena, mm-hmm. but I think we see it more in lung cancer than other types. So we call it histologic transformation in lung cancer, but it's not the only type of way that a cancer may change to either become more aggressive or evade therapy. There are other examples like in lymphoma where you have what we'd call a really low-grade lymphoma, and lymphomas are kind of cancers of the lymph nodes, and your immune system becomes cancerous, but sometimes they'll grow really slowly. So you can even just monitor some of these, and then they may have a transformation event where some small clone or something happens where you'll then get really, really aggressive disease. And the exact process that this happens across cancers can be different, and we don't fully understand it. But I will say that we can use lung cancer as the example here of when I should say a cancer can transform into something more aggressive. We'll call it histologic transformation, and I'll go into why we call it that. But I think maybe first we should talk about kind of resistance in general, because this is one form usually of therapeutic resistance. And for the most part, we're talking about adenocarcinomas here. These are cancers of things that secrete, of cells that secrete things usually locally. But adenocarcinoma of the lung, you can have adenocarcinoma of the breast, of the prostate, of multiple different areas. And those tend to be the kind that undergo this, but it's certainly not always. In the lung, that's certainly true. But I'll give the example of your tumor, Samantha, because you have a lung adenocarcinoma that has this HER2 mutation. And then we're using these really effective tyrosine kinase inhibitors, these pills that specifically target that mutation. And you can, or I should say your tumor can develop resistance in a number of ways. One way is it'll develop another mutation, which will prevent the drug from binding. So the mutation functionally keeps being active again like it was before because the drug can't block it anymore. And that other mutation is functionally, it still lets HER2 signal for the cells to divide, and the drug just can't bind. You can also develop other pathways. You mentioned EGFR. It's not the most common example, but something like that where you get another oncogene that's telling the cell to divide, and the cell no longer cares about HER2. Or at least you can successfully block HER2, and the cell will learn to rely on other things to get that signal to divide. And these are, again, evolutionary events that happen in the billions of cells that are being under this selective pressure of the tyrosine kinase inhibitor binding. What we're now talking about really today is this third bucket called transformation. We call it histologic transformation. And what that is it's a cellular reprogramming of what the cells primarily are. Or at least that's our current understanding. This is a fairly newly studied phenomena because it's fairly rare, although it's happening with increasing frequency. So what we'll see is, while on the slide, an adenocarcinoma has a certain look to it, and a squamous cell carcinoma, a different type of cancer that's frequent in the lung and other organ systems, has a certain type of look to it. But these things can de-differentiate. It can turn back into something a little more primal, something a little less regulated, less clearly adenocarcinoma, less clearly squamous cell carcinoma, and it tends to look more like small cell lung cancer for us. And there can be other small cells in the body. It's not just lung cancer that gets this small cell phenomena. It develops what we call neuroendocrine features. That's ways it might look on the slide, things it might stain with on the slide, but they tend to be more aggressive features. These things, the doubling time is shorter, the aggressiveness of the tumor is greater, and they tend to be no longer responsive to the therapies they were initially responsive to, at least if you're thinking in the oncogene space, like HER2, like EGFR, things like that. So they become no longer reliant on that signaling because they fundamentally change their wiring of what they are and what drives them. And it's a bit of an ambiguous bucket because I think we call a lot of different processes that, but the fundamental truth behind it is that it's decoupled from its dependence on whatever the thing you were targeting was. And then you're reliant on other strategies to treat it, which are not as successful.
So I have many questions. One of them is to find out that you've transformed to small cell when you have progression. And I apologize for being naive here, but is that through a biopsy only? Can that be told to you through a blood draw, like a Tempest test as an example, or is it only through pathology that you can find out that you've had this transformation?
Right now in lung cancer, and I'm using the term right now because the field is advancing very quickly. Right now, you need a biopsy.
Okay.
You need to see physical tissue.
Okay.
You need to look at it under the microscope and say, does this look like what it was before, or has this turned into something different entirely? Mm-hmm. And we have markers that you can stain the physical cells with that tell you what kinds of proteins are they expressing. Are they expressing the proteins they were before, or have they transformed? Have they differentiated into something different? Are they now expressing some of these neuroendocrine proteins, which are markers of this transformation event, markers of the more aggressive kind of tumor type? And the cells will look different. You know, if you remember in biology, you have your cell as, you know, your cell membrane, and then inside it is the cytoplasm and then the nucleus. And the proportion of those things will change. You'll have less cytoplasm, more nucleus. Your nuclei may be bigger. They may be more dysregulated. So you're getting more chromosomal issues, like you may have more of one chromosome than you did before. You may have less of one than you did before. This instability of protecting your genome can be lost. And you can sometimes even see hints of that on the slide, just looking at it. But we do more complicated testing. The reason why I say, you know, currently we need a biopsy is because some of the blood testing is changing in a way that I think we might be able to get to that through a blood test at some point with the technology we have now. We can look at how the DNA is packaged, essentially, to see what genes are turned on, what genes are being activated. And it's very feasible to identify a set of genes that is associated with these transformation events and sets of genes that are clearly not associated with these transformation events that you could possibly look at through the blood. So hopefully one day we'll have a blood test that can monitor people as they're going through treatment. And once you start to see hints of that going up, you might change what you do quickly, because a lot of times when these transformation events happen, they're pretty aggressive and you don't want to sit on them. But right now, the best we have is to wait until there's something large enough to biopsy. You look at it under the microscope and then determine, did you have one of these transformations or did you not? And that's going to inform care.
So you don't have to ask your doctor, hey, when you do this biopsy, can you test for small cell? I'm presuming the pathology just test for a gamut of things, and that would include small cell.
Yeah, you know, as I was saying, the actual look of the cells in the microscope will look different.
Okay.
Now, it gets a little more complicated, but I'll simplify and say they'll look at it under the microscope in their initial stain and say, wow, that doesn't look like adenocarcinoma.
Gotcha. Yeah.
You know, and these are things we even learn in medical school to be able to look at it and say, ooh, that doesn't have those features of an adenocarcinoma. And it will trigger the pathologist to do those other stains because they're familiar with this process very well. So they know the things to look for. There is, when we're dealing with a primary diagnosis, we often think of cancers as being in these individual buckets, almost like different species. Like, you know, this is a dog, this is a cat, this is a horse. Those are the only species I know.
Great job, Kyle.
Yeah, thank you. I've been studying. But like, imagine you have this prototype of what a dog is, and it's a wolf. Like, that's your adenocarcinoma. It's a wolf. And then you look under the microscope and you see a Chihuahua and you're like, okay, it has wolf-like features, but it looks a lot more like a cat. Like it is small, it's highly aggressive, it doesn't like me. It's much more like a cat, but it's phylogenetically a wolf. It's closer to a wolf in its origins. So this process of transformation isn't a pure, you're going from one thing purely to another thing, at least in the cell's protein makeup, in what is driving its function. But it's close enough to that other thing that we're calling it having changed to, that's how it makes sense to tailor your treatment. That's really the most important thing of why we make these distinctions, is they have to inform treatment decisions. But I think right now you'll also find descriptions of adenocarcinoma with neuroendocrine features. So it's saying it hasn't transformed into the small cell, this neuroendocrine cell, but it has some features that look like it. So that's kind of our Chihuahua kind of thing. It's like dog with cat-like features, because that's the best we can do with the tools we have right now. But a lot of these exist more on a spectrum than you'd think. Luckily, in the world of driver mutants, EGFR, HER2, those kinds of things, and we're talking about mutations here for those listening with breast cancer that is HER2 expression. The same paradigm may not be true if we're just targeting something that's highly expressed and something mutated. Maybe true. But when transformation happens, they tend to no longer be responsive to the initial therapies that were helpful in the beginning. But if full transformation hasn't, they very well still may be. So if you have some neuroendocrine features, the targeted kinase inhibitor, those pills, may work just fine. But we don't love seeing neuroendocrine features on the slide, because it worries us that this is somewhere in the process of transforming. And we know that the selective pressure of the therapy can push that transformation event. And we also know that sometimes they just transform on their own anyway.
So when you're getting a biopsy because you've progressed, and this is a side note, but I'll call it out, is that not everyone gets a biopsy when they progress, and I think they should.
And they should.
So I'm glad we're aligned there.
At least in lung cancer.
Yes. Yes.
You know, if you're in a cancer that, if you're managing a cancer, or you have a cancer, or your loved one has a cancer that has potential for this process, it's worth going through the biopsy if it would change what you do.
Right.
Not every cancer goes through this to a point where you're going to change the therapy. This tends to be more associated with cancers that have more targeted things, like hormonal therapies, like oncogene drivers, things like that. And then once this transformation event happens, most paths lead to chemo.
So sorry, that was a side note plug to get biopsies in a lot of cases. But where is there a location that small cell tends to start, as in like the pleural space or the lung? I guess why I'm saying that is if someone gets a liver biopsy and small cell doesn't come up, is there still a chance that they could have small cell in their lung? I guess I'm trying to cover all bases here of, I know you can't biopsy every single tumor that you have and get a pathology report, but to do your due diligence to ensure that you haven't transformed, is there a better place to biopsy, or is it really like, it's kind of a crapshoot right now, like we don't really know?
Yeah, I don't know if there's different data in a given cancer that has its own metastatic pattern. Like lung cancer spreads to different places than breast cancer.
Right.
Many overlap, but prostate cancer will spread to a different pattern than lung cancer. in those individual cancers, if they transform, I'm not sure the pattern's any different.
Okay.
But I think the paradigm is usually we biopsy what's growing. If all things are growing simultaneously of multiple sites of progression, our leading theory, I guess, is it's probably close enough to one another.
Okay.
I mean, it's definitely an assumption, and one of the benefits actually of these peripheral blood tools, because we know that if you take a biopsy in a large enough tumor, if that was a centimeter over to the left or right, you may get some different information.
Right. Yep.
So there's variability within a tumor, and there's variability across those tumors. The process of histologic transformation is a pretty dramatic one that I would expect one dominant thing, and that dominant thing to seed other places. But you're right. You don't know. It's definitely assumption. But I think what would possibly happen is if you're going after the resistance mechanism you identified with that biopsy, if there is small cell transformation somewhere, that probably won't respond to your next therapy as well. So you'll see something that is either residual, where everything else shrunk down really well, or something that just frankly grows through, and then you'll biopsy that, and it'll come up eventually. But it's another real need for research advancement in this space to, one, better understand this process by which these cells are transforming. Can we do anything to block it? And once it happens, can we use a blood test to better identify that? So you can't always biopsy everything.
Right.
If you progress in the center of the brain, that's not a biopsy that's often worth getting because the risk is too high. So I think we're limited, but that's a time to trust your care team, and people just do the best they can. But it's hard. It's not these are not good situations.
When it comes to small cell and people worrying about that change, I'm guessing we currently don't know, or enough research hasn't been done on who's at higher risk of this transformation. It seems to be a really bad just chance that anyone could get it, or is there certain individuals that have XYZ thing as part of their cancer that maybe are at higher risk?
Yeah, I'd love to get someone who's a real specialist in this to come on. I'll tell you the things we worry about. And I can't give you good, high quality data around it because the process of this happening is fairly rare. So the likelihood that a given institution has 100 of these is very low. I was at MD Anderson where we see a ton of patients, and even still, this process is not that common, despite hundreds and hundreds of patients going through there. So it's challenging to study it in a large group setting that gives you how likely is this poor prognosticator, we'll say, this thing that we're worried about, to facilitate it. But here's the thing that I'll say we worry about. Small cell lung cancer tends to have mutations in two genes, P53 and RB1. Now, those are genes that regulate the cell cycle, and they regulate the cell's ability to divide. They usually will tell the cell to slow down on dividing. So when they're lost, the cell will divide aggressively. Those mutations are not unique to small cell, or they're not unique to neuroendocrine tumors. So when we see that in adenocarcinoma or in another kind of cancer, it does make us worried that this already has some of the things that are associated with a small cell anyway. So and we know that P53 tumor suppressor genes being lost, those kinds of things, those kinds of mutations, that they're associated with worse outcomes generally. To the individual, it may not mean much, but at a population basis, we worry. That being said, those are really common.
Yeah.
A lot of people, P53 is the most commonly mutated gene in cancer. So it's not surprising that we see that in the aggressive forms, but it definitely makes us, I would say, a heightened awareness that this is something that could transform. And then if something has elements of dedifferentiation, borrowing that analogy before, maybe it doesn't look perfectly like a wolf. It's starting to look more like a husky. And you're like, this is already looking different than normal or than normal lung. So maybe it's already on that path. And we're facilitating its evolution down that path to dedifferentiate, to turn into something less clearly from what it was in the beginning. And that might be associated with not responding to therapy as well. Those are the things I tend to look for. But it's hard because we have very few models of this in the laboratory. And the models that we do have are really complicated, and they're good tools to use, but I don't know if it totally gets at the human biology. And it's such a rare event. We don't have a lot of tumor tissue to study. You'd love to have the ability to track these over time, but if it only happens in single digit percentages, which is probably where I'd ballpark it at, then you have to capture a lot of people before it starts, and then keep sampling them, either biopsying their tumors, using these peripheral blood tests. You'd have to get a lot of numbers. So we'll get there just through other projects that are ongoing and other studies that we're doing. But I think it's going to take a while to get a critical mass of patients that have enough research data to inform us more about what this process really is.
What is there a time window of when this is more likely to occur? And what I mean by that is, again, a side note, but I think relevant to the conversation. So like LMD is an example, right? LMD is
leptomeningeal disease.
Thank you. Is another thing of progression that people get very nervous about. And I think they're finding, and correct me if I'm wrong here, finding more and more that it's happening more often now because people are living longer with their disease. And so things are evolving that way because people are living longer. And so I'm just curious with small cell, if we know, this might happen more likely to happen at the 18th month mark, or is this more likely to happen at the 6-year mark because the cancer is trying to evolve at that point of time, or did we really just have no idea?
Yeah, it's a great question. And I won't say we have no idea. I think it's happening. I think it is happening more often because individuals are living longer. So there's more time for that event to occur.
Gotcha. Yeah.
But there's also a bias in that assumption that I'm giving, because as early as 10 years ago, we didn't have a whole lot of reason to do additional biopsies when someone progressed. If someone was on the first or second tyrosine kinase inhibitors that we came out with, well, all you have next is chemo. There's no other thing that you're going to be able to target. So the ability to target those initial resistance mechanisms that I mentioned, if there's a resistance mutation in the gene that you're targeting, maybe a different drug can bind at a different place at that gene, like HER2, for example. Now, if you have another pathway that's activated, we have things that might be able to target that. So it totally makes sense to biopsy and look, because we can target it. We can change treatment based on what we find. We might find histologic transformation, but that might have been happening before and we didn't know because there was no reason to look.
Right.
The biopsy wasn't going to inform anything. So I think it's possible that we're finding more of this because we're doing more biopsies for people that are on treatment. We're doing a better job of identifying the driver mutations for lung cancer, at least. So we have a better sense of what are the things that we should be giving really good therapies for. Back in the day, it was just chemo for everybody. until 20 years ago. It was chemo for everybody. So I think that certainly matters a lot. And then once it became known that some of these tumor types can transform and you might change what you do across many different types of cancers, then it became a little more routine to look. So I think we're still catching up to that even being routine, because as you mentioned, many people don't get biopsies. That's very true. So the data, I think the data is still lacking, but as a field, we're getting there.
Okay. Good to know. For someone that might have transformed to small cell, I guess, what are their options?
Yeah, it's a tough question. I'm going to use lung as the example here. But many, actually for small cell cancers, many other tumor types will borrow the guidelines from lung because it happens much more frequently in lung. So I'll say small cell lung cancer in general is usually a disease that we associate with carcinogen exposure because it's highly mutated. So it's usually associated with smoking.
Yep. Well, I will say also a lot of firefighters, and I know this because of working in public safety, a lot of firefighters actually get small cell because of their exposures. Yeah,
I believe it. I think the same process of carcinogen inhaling debris as well, and things that lead to chronic inflammation in the lung, those are the things that I think trigger small cell. But it's not always the case. Like every other cancer, there's always exceptions, and you can certainly attest you can do everything right and still get diagnosed with a certain cancer. So I'll say that's usually what we're thinking of when we think of small cell cancer. It's most commonly in the lung. So other tumor types will borrow the information that we've used in lung to see what works and what doesn't. So once something transforms into a small cell, a lot of times you're looking at chemotherapy backbones. You might be able to add one thing or another thing. But for most folks, since these cells divide rapidly and they have lost their ability to regulate cell division, they weren't doing a great job in the first place. But once you've taken off these tumor suppressor genes that are usually mutated, the P53, like I mentioned, the chemotherapy tends to be pretty effective. The challenge with that is chemotherapy is really effective, but most of the time, these cancers still evolve quickly. A lot of times when this event occurs, since the cancers can grow quickly, it can get out of hand pretty quickly, and that you can get disease that's spread very aggressively. And sometimes that's the triggering event in someone who has a cancer that's usually fairly well behaved, like a prostate cancer, for example, which can sometimes, even metastatic, they grow very slowly. And then you might do another scan, and you'll see there's disease that's spread to multiple organs. It's large in volume. And you'll say, okay, we definitely need to look for small cell because this is acting way more aggressively than it should. So that heightened aggressiveness, the more it's dividing, also makes it more susceptible to chemo. But at the same time, it tends to evade the chemo, learn how to develop resistance fairly quickly, in the order of a year. 6 months to a year can be how quickly it can evade chemo. That being said, there's also a lot of therapies that are coming out in small cell lung cancer now that were not available 2 years ago. These are therapies that leverage the immune system, therapies that target certain things on the cell surface and deliver really aggressive chemos directly to the cancer cell. Similar to the Enhertu you were on, we have other antibody-drug conjugates that are really useful in small cell lung cancer, and I think that could be extrapolated to other types of small cell. So there's stuff we can do. And a lot of people will ask, if you're on a therapy before, should you continue that therapy? For example, you're on a drug that targets HER2. Should you keep that on after a transformation event? And I think this is definitely a place where reasonable minds may differ, and individuals need to talk to their oncologist about their specific circumstance. But it's not crazy to continue those things, in my opinion. I will frequently say that where in the body, the drug stopped working, but you don't know where the drug continues to work.
Right. That's my new slogan, by the way, whenever I talk to people, because of you saying that.
Yeah, that's a consideration I have.
Yeah.
But there's also a concept, and this is something I think I appreciate because I do a lot of stuff in the lab, where if you add on a drug and the growth rate slows, you'll still see progression on the scans. If it's growing half the rate it was before, that's still good in my mind. And this is just kind of where my practice style comes in. So and that's hard to know truly if the drug is doing anything, but it may be an additive effect of the chemotherapy or whatever other therapy, plus maybe the tyrosine kinase inhibitor you were on. But this is an area I think other oncologists may disagree with me, and reasonably so, because we just don't have a lot of data here. So I think it's important, particularly when these kinds of rare events come up, very nuanced events. All of these are going to be, patient by patient in what we should be doing. So it's really important to talk with the care team. And if you need a second opinion, don't be ashamed of getting that second opinion. Don't be worried about offending your oncology team. And these things are really, really complicated. And I think most practicing oncologists will say reasonable minds may differ here.
So let's go into immunotherapy a little bit, because I'm curious. So if we're getting very specific, right, for a large bulk of mutations, immunotherapy it's not necessarily that effective. I mean, it depends on your mutation, but generally. So when you transform to small cell, why does small cell enable the immune system to be harnessed?
I don't know that it does.
Okay.
Small cell is the standard of care regimen for small cell includes immunotherapy. And for those who are listening and haven't heard of it, well, I guess you're all listening. Immunotherapy is what we're talking about here are antibodies that we give to essentially unmask the tumor from the immune system. Tumors develop this ability to hide from the immune system, and tumors are really abnormal. So your immune cells may want to clear them. And this antibody removes a checkpoint to them. They're called immune checkpoint inhibitors. So the initial studies that showed immunotherapy to be helpful in small cell lung cancer benefited people for about 2 months.
Oh, wow. Okay.
In the median.
Okay.
And different data shows that it's a subgroup of people that probably get benefit.
Okay.
So I think for most individuals, we just don't know exactly who they are. But for most individuals, it's probably not helping very much. But we add it because we don't know if that's you or not. Some people get really good responses. So that's small cell lung cancer as its own entity. For the individuals that transform, these are the nuances that I don't know that I biologically fully put them in that bucket, because they started with an oncogene, other things happened. So I don't know if starting as adenocarcinoma or squamous cell carcinoma or some other form of cancer, and then transforming into what looks like small cell, holds the same rules. Does immunotherapy truly not work as well in these individuals? I don't know that we have great data in that area. So I think it's a very reasonable thing to use. It may work better. It may work worse. I just don't know. The challenge often becomes for combining therapies. You certainly don't want to do anything that's harmful. And occasionally some of these therapies can be harmful with immunotherapy. Immunotherapy revs up the immune system. And if you're on a medicine that can cause some immune system issues, which some of these therapies can, combining them may be dangerous. So it's at least something to have that clear discussion about with the oncologist, because it's definitely a medicine by medicine circumstance. But yeah, they're challenging questions. They're very good questions, good nuanced questions, particularly around is this cell closer to adenocarcinoma, closer to the small cell cancers, I think these events are somewhat on a spectrum, but we don't have a good way of teasing that apart. And we don't have a good way of changing what we do based on where in the spectrum this particular tumor lies. So we're kind of forced to take a continuous variable, which is the variable of adenocarcinoma, to de-differentiated state, I'll call it. Small cell is what we're calling it. So I think it's a continuous variable, but we have to put them in buckets because we don't have a lot of treatment options. And frankly, I think we're doing the right thing by doing that with what we have, but chemotherapy ends up being largely the big backbone. And then different types of immune therapy, I'd say.
Okay. Are there particular mutations where this is more likely to happen, or is this a total crapshoot again in terms of, I don't know why I keep on saying crapshoot. I don't even think that's a term.
I don't think it is, but it's more
more appropriate.
Yeah,
we'll go with crapshoot. I don't know where.
We're not going to get banned by any of the advocacy organizations with that one.
I don't know where I got that from. Sorry about that. But yeah, is it more common in particular mutations? I'm seeing it a lot in EGFR. I say a lot. I'm seeing it more often in EGFR specifically. And I wonder if that's just because there are more people that have EGFR, or there's something about EGFR and the TKI that is utilized that might, because it's so good, is it creating more pressure than maybe other TKIs for other mutations?
I think that's true. I've seen it in multiple oncogenes.
Okay.
But again, this is so rare that you don't know.
Yeah.
Is it going to happen? Let's take HER2, for example, 2% of lung cancers.
Yep.
So for a given oncologist, they may come across one in their lifetime.
Yep. Which
so
is
it's
crazy.
Really hard. Yeah. And it's probably going to be you because, but we don't personally have the denominators in our clinical experience. So we can say what we see, but EGFR is one of the more common driver oncogenes in lung cancer. So we see it a good deal there. I've seen it in patients with ALK, which is also, enriched in the centers that I've worked at, because that tends to be where trials are run out of, and that's where individuals with these rare things tend to go. But I think our understanding is if a cell is driven by these oncogenes, then this is one of the escape mechanisms that can be utilized. And I think one thing we've noticed is as our first-line therapies get better, people are on them for longer. But when they come off them, when it stops working, it's less commonly due to another mutation in that protein that we can target. It's more commonly due to one of those other things. Something else is activated, or it just becomes this de-differentiated thing on that histologic transformation spectrum. So I think it's happening more possibly because our drugs are getting better, which is kind of a sad irony of it.
Yeah.
Although the flip side of that is, as you mentioned, people are living longer. So I think the tumor cells undergoing that selective pressure, remember what happens when we treat someone with one of these really effective therapies is you start with billions of cells to trillions of cells, and then that all shrinks down, 99% die, and then 1% of that very large number is, or 0.1%, is still a lot of cells that have figured out some way to survive that event. And you may not even be able to see it on a scan, but there's probably going to be some residual cells there that have at least learned to exist. They may not be growing, but they've learned to exist. And then it's at some point, something has to change in the cells while that TKI is still there for an evolution bottleneck event. And I think of this the same way you would think of this under, your Darwinian genetics, or when I think about that, I think of the genetic tree, the 2x2 grid. But if you think about an evolutionary bottleneck on the Galapagos or something, you're going to get one weird thing that tends to do okay there, and then that sprouts out a new whole species, a whole new population. So evolutionary biology, I think, is exactly what we deal with in cancer genetics and cancer biology. So if it's unable to resist by one mechanism, because the drug is so good, it's unable to resist by another mutation in that protein, it's going to resist another way. It may take longer. It's maybe harder for the cell to do that. More chance events may have to happen for this dysregulation to occur. But for us, at least, it tends to lead to some more aggressive things at progression.
And that's why sometimes I think, well, myself included, we think doing everything is better than not. And I do wonder, given this conversation, other conversations I've had recently, is almost if you're too aggressive with your approach, that might backfire, which is kind of scary. And I know it won't necessarily backfire with everyone for a certain period of time, right? But it could really backfire because you're just providing so much pressure to the cancer that it's like, oh, and I give my cancer thoughts, right? So it's like, oh, I need to get away from this. This is like too much, rather than just hitting it one way and it kind of just hanging out.
Yeah, it's hard to know. Generally speaking, we want to be as aggressive as we can up front. And I think that's a good strategy, at least with the tools we have when that becomes particularly challenged, is when you're going to take something you would have given later and you just push it in front now. Right. So now they're already resistant to that when you would have given it. And that's a really good reason to be critical of data and studies that's coming out where they're combining things. If they're combining something that you might have gotten anyway, and you see that it's better than not combining it, at least in terms of progression, then you have to think critically, is that worth it? Or is what you're seeing just what you would have gotten sequentially? A good example of that is these tyrosine kinase inhibitor pills and chemo.
Yes, that was on my mind.
Yeah. We had to think really critically as a field that when we put them together, people, their tumors are controlled for longer. Was that better or the same or worse than if you were to do them in succession? So I think in that circumstance, we thought very critically, and a lot of people are combining them now, at least in EGFR. But that assumption may not be true in other contexts. So these are definitely nuances to consider, and keeping in mind that small cell transformation is usually treated with chemotherapy. If you're really aggressive about just pounding with chemo, you may force that to happen and not have much to reach for. And who knows, maybe that's still the right call. We just don't know. But it speaks to your point that pushing it all up together in the beginning as an assumption that it's going to be better isn't an assumption you can make.
Right. Yeah. I don't know why this is top of mind for me recently, but it's like, okay, well, you're combining these things and it might give you more time in the front end, but when you do progress, does it progress into these more crazy things because it got so much pressure at the beginning? And I guess we'll learn more and more about that. And it seems to be, correct me if I'm wrong, that the chemo plus a TKI seems to be very patient-to-patient specific. Like if they have higher risk initial diagnosis, whether that be brain or liver mets as an example, then you're more likely to do a combo up front to really hit it, but you still have the risk at the end of what the progression might be, and we just don't know the data yet.
Well, it's going to depend on how good the therapy you're combining it with is.
Right.
If that kills everything anyway,
right,
then what was the point of the chemo?
Right.
If that's really, really good, which we have some compounds out there now that I wouldn't expect there to be much of a difference, but that's why you do the study.
Yeah.
But I want to kind of pose the question back to you, because there's a lot of anxiety around small cell transformation. What are you hearing in the patient communities? What are the whispers that make you concerned?
I think it's the fact that, and again, you said maybe we're seeing it more because we're just biopsying more, or we're seeing it more as a patient community because we're on these social media platforms, right? So we interact with more people and we see it. But I think the concern is that we are seeing it more, whether that be it hasn't changed, but we're just seeing it because we're interacting with people more. And so it's a concern, I think, especially in the EGFR community, because that's where we've seen it recently for quite a few people. And whether that be EGFR exon 19 or other exons, it doesn't seem to matter there. We've seen it in various situations. And so I think it just freaks people out, because it is a thing of, well, I know what cancer I have. Like I said before, I know what cancer I have. I know what my treatments are going to be. I know what my plan's going to be. And so to suddenly be told that there could be a chance that my cancer could evolve into this completely different thing that is highly aggressive. Small cell has a stigma associated with it that it is highly aggressive. I think it's just a fact, right? And so it's terrifying to people. And there's really not much you can do. And so it's kind of just like, is my cancer going to evolve this way or not? And I think the passing of my friend Caroline, she was very well known in the community. It's got everyone very scared, because they saw how quickly small cell, changed and evolved in her cancer, and she sadly passed away. And so it's put people on heightened alert, I think, that this could happen. But I also think there's a lot of people, and this is why she wanted me to do this podcast, is there's a lot of people out there that don't know that this can happen. And it's not, this podcast is not a scaremongering tactic, right? I don't want people to freak out. Although I will say that I personally worry every day about my cancer forming resistance and changing into these weird things we just don't know about, right? I mean, I think that's just a general concern of people, but the change to small cell just seems to be this massive elephant that is absolutely terrifying. And so I think it's important to inform people that this is a possibility, even though a very small possibility. It can happen. And so just to be pushing for those biopsies when you have progression, and to be aware that this could appear on your pathology report at some point, and to take action when you see it. I mean, obviously your oncologist is going to take action, but I think for people that don't necessarily know that this is a thing and maybe read it on their report, they would just be like, oh, okay. And it's something that you need to attack very quickly and take action. And so I think that as soon as you see that, you need to kind of alarm bell your team and be like, okay, we need to target this like now.
Yeah. And how long in the patient community is the perception of how long individuals live for after this transformation?
I don't think there is that much perception on that yet, other than just small cell is highly aggressive.
Yeah.
So that's just kind of an over looming thing that, I mean, it's similar with LMD, I think. Sorry to talk about LMD a lot on this podcast too, and I know we're going to do a podcast on it, but it's the same kind of thing when you're told you have LMD, you know that your time to live might be a lot more restricted, and that is probably the case with small cell too.
Yeah, I think on the whole, that's true.
Yeah.
But I do know individuals, to offer hope for those listening. I do know individuals who have had that transformation to small cell and lived for years. They're still alive. They've
Oh,
lived
wow.
for years.
Okay. Thank you for providing that hope. That's good.
Yeah, and this is a balance I try to strike with my patients too, is you want to be realistic, but you also want to take whatever hope you can get. And that's real. These are not based in made up situations or just wishful dreaming. There are individuals who do really well despite these challenges. It's not the majority, but they exist. And I think, we need to hold on to those elements of hope where we find them, while still acknowledging the objective reality that things are challenging. And, if you're undergoing a small cell transformation or some other histologic transformation event, not to sit on it and definitely seek the best care you can get quickly. But it's not all hope is lost, because I think that's a huge element of what we need to provide in the medical community is, we talk a lot about progression-free survival, about overall survival, which therapies work best in shrinking tumor. But additional lifetime gained only matters if that is valuable lifetime. Mm-hmm. And if someone is just overwhelmed with despair, then I don't think that's tremendous value that we're adding.
Yep.
So I think it's important that we instill the hope whenever we can get it, even in these challenging situations, as long as it's based in reality.
Yeah, absolutely. No, I appreciate you touching on that, because some people might be listening who have transformed, and I definitely want to give them hope there. I don't want to be all doom and gloom, because there are those nuanced situations where, where there's hope. And I get, and I will say, like when I read about these different transformation stuff or different resistance mechanisms, they make me so depressed and sad and just anxiety ridden. And so I don't want someone listening to this to necessarily feel that way, and know that there are, the positives are there are medicines, right? That can attack this transformation, and there is hope there too. So I don't.
And it's still responsive to radiation.
Yep.
There are things you can still do.
Yeah.
We're talking about population statistics, but again, to the individual, that may not be relevant. Mm-hmm. That happens a lot, where the statistics as a general may be poor.
Yep.
But individuals we know do very, very well.
Yep.
So I think any last sentiments before we cut loose with that bit of optimism?
No, I think that was a good way to end.
All right. Well, sounds good to me. Thank you everyone for listening. Again, this has been Cracking Cancer, and you can go to crackingcancer.org for more info. Thanks, Samantha.
Thank you.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.